Hello everyone, this is Jim Moeller. I am the Director of the Sports Medicine Fellowship at Henry Ford Health System in Detroit, Michigan. Welcome back to the Fellow Education Video Library. This is one of a series of lectures on the effects of exercise on chronic illness, and today we are going to be focusing on diabetes mellitus. We will be discussing some of the basics of diabetes, including pathophysiology, diagnosis, and general treatment. And then we will get into specifics regarding the effects of exercise on diabetes mellitus. I have nothing to disclose, so let's get started. To begin with, we have to remember that there are two types of diabetes mellitus. Type 1, where the body does not produce enough insulin. The primary treatment in this case is insulin administration. This used to be called insulin-dependent diabetes or juvenile diabetes. And then there's type 2 diabetes where the body produces insulin but does not respond appropriately to it. And this is more commonly associated with aging and with obesity. This used to be called non-insulin dependent diabetes or adult onset diabetes, but again, the current nomenclature is type 1 diabetes mellitus and type 2 diabetes mellitus. Type 2, though commonly associated with aging, is becoming more and more common in younger age groups, which we will discuss in just a moment. First, let's talk about some statistics. The numbers that you see here are regarding the young population. So this is looking at the under 20 age group, and these are statistics from 2014-2015, which showed an incidence in the United States of type 1 diabetes at just over 18,000 and a prevalence of 187,000. Whereas with type 2, the incidence was nearly 6,000 and a prevalence of 23,000. So as I said, there is an increase in the number of cases of type 2 diabetes mellitus in younger people. Now, some of these folks are over the age of 18, so we have to consider these numbers with that in mind. The graphs on the right show the change in the prevalence of type 1 diabetes at the top of the image and type 2 diabetes in that 10 to 19-year-old age group. And over that time period, there was a significant increase in prevalence of both types. Now, the graph may be a little bit difficult to understand. The dotted line is the overall change in prevalence. The grayish line, which is at the top of the type 1 diabetes and the bottom of the type 2 diabetes, is the white non-Hispanic group. The teal color is the black non-Hispanic group. The purple is the Hispanic group. The darker blue is the Asian Pacific Islander group. And that's true for both graphs. So type 2 diabetes in that younger age group, much more prevalent in the non-Hispanic black population than in the white population, and it's reversed in type 1 diabetes. Some more statistics show that in the United States, nearly 27 million Americans have diabetes mellitus. And that's people who have the diagnosis. It's estimated that there's another 7.3 million who are undiagnosed and almost 88 million adults with what is termed prediabetes. The majority of these cases are type 2 diabetes, and you can see from the graph that as the population ages, the prevalence increases. What you also see is the prevalence is higher in males, and the highest prevalence is in the non-Hispanic black community. If you look at the prevalence county by county throughout the United States, and this compares data from 2004 to 2016, you can see consistent increases in the prevalence of diabetes mellitus across the country. When you switch from prevalence to incidence, approximately 1.5 million new cases of diabetes mellitus was diagnosed in adults in 2018. The highest incident rate was in the 45 to 64-year age group, followed by the greater than 65-year age group, and it was highest in Hispanic and non-Hispanic black races. Another thing to consider with patients with diabetes is that they also have other conditions at a frightening rate. 21.6% of patients with diagnosed diabetes are current smokers. Almost 90% are either overweight or obese. And nearly 40% are physically inactive, with only about 25% meeting the recommended 150 minutes per week exercise goal. A1C control is poor. Hypertension levels are high, as are hypercholesterolemia issues. When you look at obesity, 15% had extreme obesity. When you talk about A1C, 15% had a value of greater than 9%. When you consider positive health parameters, specifically A1C value of less than 7%, blood pressure of less than 140/90, non-HDL cholesterol less than 130, and being a non-smoker, less than 20% of diabetic patients met all of those criteria. Diabetes is the 7th leading cause of death as of 2017 data, where 83,500 patients had diabetes listed as the primary cause of death, but it was listed as a contributing factor in nearly 200,000 more. And you can see that the costs, both direct and indirect, are very, very high. So clearly, diabetes mellitus is a very, very important medical condition, not only in the United States, but worldwide. Therefore, we need to make accurate and early diagnosis and start appropriate treatment plans to try to assist in lowering the morbidity and mortality from diabetes mellitus. So let's talk a little bit about making a diagnosis. First of all, you can screen patients for diabetes mellitus. When it comes to type 1 diabetes mellitus, screening is not recommended. For a screening test to be appropriate, a test has to be available. There has to be an asymptomatic period when treatment would be beneficial, and there has to be a beneficial treatment available during the asymptomatic period. In type 1 diabetes mellitus, patients typically will present with an acute onset of symptoms, and the classics are polyuria, polydipsia, and polyphagia, often with weight loss despite the increased caloric consumption. And at that time, blood sugar is measured in order to determine whether the patient has type 1 diabetes mellitus. Sometimes the initial presentation is diabetic ketoacidosis. So because they present with acute symptoms, there is no established cutoff value for antibody testing, there's no accepted treatment for asymptomatic patients, and no medication is available to prevent the disease in persons genetically predisposed to type 1 diabetes mellitus, screening is not recommended for this condition. When you talk about type 2 diabetes mellitus, however, there are screening recommendations. The United States Preventive Service Task Force recommends screening for abnormal blood glucose as part of cardiovascular risk assessment in adults age 40 to 70 who are overweight or obese. The specific recommendation goes on to say that clinicians should offer or refer patients with abnormal blood glucose to intensive behavioral counseling interventions to promote a healthful diet and physical activity. The reason that screening is recommended is that there are reliable tests available, and lifestyle changes and medications reduce progression and adverse sequelae of the disease, even in people who are initially asymptomatic. Screening for type 2 diabetes does not improve mortality after 10 years of follow-up, but studies do show that lifestyle and pharmacologic interventions in patients with impaired glucose tolerance and impaired fasting glucose can delay development of type 2 diabetes, with some studies showing greater effectiveness with lifestyle changes over the medications. Now, the USPSTF does not have a current recommendation for screening anyone under the age of 40 for type 2 diabetes mellitus, but if you look at the American Diabetes Association, they recommend screening children and adolescents 18 years and younger who are overweight, and they have a number of definitions for overweight, and have 2 of the following risk factors. 1, a family history of type 2 diabetes in a first or second degree relative. 2, belonging to a high-risk ethnic group. Or 3, they have acanthosis nigricans, hypertension, hyperlipidemia, or polycystic ovary syndrome. Going back to the USPSTF, they give an I rating for screening asymptomatic adolescents for hypertension, hyperlipidemia, saying there is insufficient evidence for or against screening. So it could be difficult to know if adolescents have those problems to put them in the high-risk group that the ADA would recommend for type 2 diabetes mellitus screening. Both the ADA and the American Academy of Pediatrics recommend screening at-risk patients every 2 years starting at age 10 or at the onset of puberty if that's before the age of 10. So how do we make a diagnosis? There are a number of different ways. A hemoglobin A1C greater than 6.5% is one way, but this test should be confirmed with repeat testing if there is an absence of unequivocal hyperglycemia. Fasting glucose level of 126 or greater, a 2-hour plasma glucose of 200 or greater after 75-gram anhydrous glucose load dissolved in water, or plasma glucose taken randomly that's greater than 200 with classic symptoms of hyperglycemia. So all of these are diagnostic tools. It is considered that the fasting blood glucose from a venous draw is probably the best method. Now, we talked about 88 million people in the United States with prediabetes. Prediabetes is diagnosed as a fasting plasma glucose between 100 and 125, or a 2-hour plasma glucose during the oral glucose tolerance test between 140 and 199. So if we have a patient who we have made the diagnosis of diabetes, how do we manage this patient? In type 1 diabetes, it's very important to regularly monitor and control glucose levels. The goal is to have an A1C of less than 7%, preprandial glucose between 80 and 130, and a peak postprandial glucose of less than 180. Now, certainly more stringent controls can be attempted, particularly if there's a low risk for hypoglycemia or during preconception pregnancy situations, and a goal of less than 6.5% could be considered in that time. But less stringent controls are also okay, especially if someone has a history of severe hypoglycemia or a low life expectancy or advanced microvascular, macrovascular complications. Approximately 80% of people with type 1 diabetes mellitus will do their self-monitoring with finger stick. This takes roughly 6 to 10 measurements a day, including before each meal, before exercise, before bed, sometimes after meals, or certainly if hypoglycemia is suspected. It is certainly the less expensive way to monitor glucose. Continuous glucose monitoring has been associated with improved glycemic control, but at a higher cost financially. In this situation, a sensor is inserted into the subcutaneous tissue, and it measures interstitial glucose levels in real time and transmits those readings to a receiver device with a monitor screen, as you see in the photo below. The effectiveness of continuous glucose monitoring devices does not completely eliminate the need for capillary testing. You still need to do capillary testing for device calibration or to confirm abnormal levels. Data do not show a definite reduction in overall severe hypoglycemic events with the use of continuous monitoring. However, the monitor does have alarm features and trend alerts and can notify patients and caregivers to expeditiously administer treatment if hypoglycemia is on the horizon. So staying with type 1 diabetes mellitus and management ideas, we have to provide them with insulin because these people are not producing insulin. The islets of Langerhans in the pancreas are no longer functioning in that way, and so we have to provide them with exogenous insulin. I'm old and have been at this a long time, and we always used basal and mealtime bolus injections in the treatment of our patients with diabetes. Calculating the initial doses beyond the scope of this lecture, that we would use long-acting insulin for basal demands and short or rapid-acting insulin for the bolus demands. The advent of insulin pumps has changed the game, certainly. Here you see a picture of one of the early insulin pumps. Back in those days, the pumps weighed nearly 30 pounds and had to be worn as a backpack, and certainly were not convenient. Now, pumps are certainly much more portable and easier to carry around. There are two kinds of pumps. The conventional portable insulin pump consists of an insulin reservoir, a computer chip to manage dosage delivery, and an infusion set with flexible tubing, as you see here. The unit can be clipped to a belt or waistband, and a soft plastic cannula at the end of the tubing inserts under the skin for delivery of insulin. Another form of insulin pump is a patch pump, which attaches the unit directly to the skin and does not require a line of plastic tubing to deliver the insulin to the cannula. The system receives insulin delivery programming via a wireless handheld unit. In both types of pumps, the cannula should be removed every 2 to 3 days, and the injection site should be rotated to avoid lipodystrophy. There are many things to consider when thinking about dosing of insulin, including pre-meal blood glucose level, the planned meal, and planned exercise, but that's more of an issue with the bolus injections than with the pump, because the pump can easily be adjusted for real-time changes in insulin delivery. Plus, with the pump, generally you're using very rapid-acting insulin. Other components of treatment include dietary counseling and physical activity, and certainly we're going to focus on the physical activity in just a little bit. When treating a patient with type 1 diabetes mellitus, it's important to remember that certain other areas of their medical health should be followed on a regular basis, including blood pressure, BMI, review of the blood glucose logs, smoking cessation, and contraception or preconception planning, which should be discussed at every visit. And annually, there should be depression screening, a foot examination, a dilated eye exam, and a dental exam. The first dilated eye exam can be performed 3 to 5 years after diagnosis because, again, with type 1 diabetes mellitus, you generally know the timing of onset because the patient was brought in by symptoms. This is different than what you see in the type 2 diabetes mellitus, which we'll discuss in a moment. A1C should be measured regularly until they've shown good control. A urine albumin creatine ratio should be looked at annually. Lipid profile should be initially assessed, and then as needed, TSH, creatine, and LFT should also be considered. In this population, vaccination should include Pneumovax, which is repeated at age 65, an annual flu shot, and the Hep B series. So let's switch gears and talk about type 2 diabetes mellitus and the management thereof. Self-monitoring is not recommended in patients who are not on insulin. Glycemic control goal is the same as it is with type 1 diabetes mellitus at an A1C of less than 7%. Even though you can consider tighter control, studies have not really shown this to be associated with an improvement in all-cause mortality. And certainly tighter control should not be considered in patients with long-standing type 2 diabetes mellitus or established cardiovascular disease, as it may increase mortality. Remember, too, that attempts at tighter control will increase the risk of hypoglycemia, especially if these patients are on insulin or an insulin secretagogue medication. As with type 1 diabetes, dietary counseling and physical activity are also important in the type 2 diabetic. When we talk about medications, there are way too many medication classes and individual meds to review, but remember that metformin is the initial medication of choice if there are no contraindications. The laboratories that should be drawn and followed are similar to what we discussed in type 1 diabetes mellitus. When you talk about annual checks, the dilated eye examination should be performed annually, and the first dilated eye examination should take place as soon as possible after the diagnosis of type 2 diabetes mellitus has been made. The reason for this is that these patients may have had a significant asymptomatic period in which microvascular changes were taking place, and therefore there may be significant eye changes by the time you make the diagnosis. Again, this is different than the type 1 diabetic, where the initial examination could be 3 to 5 years after diagnosis. So let's start talking about diabetes mellitus and exercise. Before starting an exercise program, it may be important to do some pre-exercise cardiac screening. Experts recommend that deconditioned patients undergo exercise stress testing before starting a vigorous exercise program in certain cases, and these cases would include men over the age of 45, women over the age of 55, deconditioned patients with 2 or more risk factors for coronary artery disease independent of diabetes status, as well as deconditioned people with diabetes mellitus. The problem is there are no studies that have compared outcomes from pre-exercise stress testing versus encouraging light exercise with gradual increases in exertion. So we don't know if pre-exercise testing leads to better outcomes. That better outcome, of course, being reduced risk of death from exercise itself. The existing American College of Sports Medicine exercise pre-participation health screening recommendations stipulate that people at moderate risk for cardiovascular disease undergo a medical examination prior to starting vigorous exercise program. And the vigorous would be achieving 6 METs of work during exercise, or greater than or equal to 60% of maximal predicted heart rate. An individual is considered at moderate risk for cardiovascular disease if he or she is asymptomatic and has 2 or more risk factors. So again, if they're asymptomatic with 2 or more risk factors for cardiovascular disease, medical screening prior to the onset of exercise is recommended by the ACSM. But the medical screening, it does not specifically say whether that includes cardiac stress testing. Now, the ACSM also recommends that people at high risk for cardiovascular disease undergo a medical examination and diagnostic exercise testing before beginning either a moderate intensity or vigorous intensity program. Moderate intensity being between 40 and 60% of maximal predicted heart rate, or 3 to 6 METs of exercise, where again vigorous would be greater than or equal to 60% of maximal predicted heart rate, or 6 METs of exercise. People at high risk would include those who are symptomatic from cardiovascular disease or have known cardiovascular disease, metabolic disease, including diabetes mellitus or renal disease. So let's say we have a deconditioned patient who has known diabetes mellitus, which would be the metabolic disease, and is asymptomatic. They want to start a vigorous exercise program. Certainly medical clearance would be recommended in this situation. Because they want to start a vigorous program and they have diabetes, regardless of their symptomatology, they should obtain a cardiac stress test as a part of that medical clearance. If they want to start a light exercise program, then obtaining a cardiac stress test as part of the medical clearance is at the discretion of their medical provider, especially if they're under the age of 45 for a male, under the age of 55 for a female. If their plan is to start a vigorous exercise program, then certainly addition of a cardiac stress test is recommended. What about the patient who is an active exerciser? If we take somebody who is already participating in regular exercise and they have known diabetes mellitus or cardiovascular disease, and they want to continue with moderate intensity exercise, a medical clearance is not recommended, or certainly not considered to be necessary, I should say, by the ACSM, and they can continue with their moderate intensity exercise. If, however, they want to increase their level of exercise to a vigorous exercise program, then medical clearance should be obtained prior to that change, and the addition of a cardiac stress test should be considered as well. So it's important to understand whether the patient is a regular exerciser and is conditioned, or is someone who is deconditioned. It's also important to define what the plan is with regards to intensity of exercise, so you can make appropriate decisions on pre-exercise screening. Let's talk now about type 2 diabetes and exercise. We know that exercise increases glucose uptake from the blood, and this is through 2 well-defined pathways that stimulate glucose uptake into muscle. At rest and after meals, glucose uptake by muscle is insulin dependent and serves primarily to replenish muscle glycogen stores. This pathway is impaired in type 2 diabetes mellitus because of lack of sensitivity to insulin. The second pathway is that during exercise, contractions will increase blood glucose uptake to supplement intramuscular glycogenolysis. And the glucose uptake into working muscle through the muscle contraction pathway is normal in type 2 diabetics even when the insulin-mediated uptake is impaired. So this uptake relies on glucose transporter proteins, and the GLUT4 protein is the main isoform for this transport, which is modulated by both muscle contraction and by insulin. Contracting muscle activates the GLUT4 protein, and this effect will last for hours after the exercise has ceased. Both aerobic and resistant exercises will increase the GLUT4 abundance and blood glucose uptake even in type 2 diabetics. Remember, these pathways are also present in type 1 diabetic patients. So you'll see this slide again. So the acute effects of moderate exercise in a type 2 diabetic patient are that there will be increased blood glucose transported into the muscle due to the contracting muscle. And again, this can last for hours after the exercise is completed. Exercise will also increase insulin sensitivity, which will drive glucose levels down. Therefore, the utilization of glucose rises more than hepatic glucose production takes place, and blood glucose levels will decline. The thing is that even though there's increased insulin sensitivity during this time, plasma insulin levels will fall due to exercise, so hypoglycemia is unlikely. Where the muscle contraction GLUT4 stimulation lasts for several hours after exercise, increased insulin action and glucose tolerance can persist for up to 3 days after a single exercise session. So that's the effect of moderate exercise. What about intense aerobic exercise? Well, in that situation, plasma catecholamine levels will rise markedly, driving a major increase in glucose production. Therefore, hyperglycemia can result from this type of activity and persist for an hour or two. And that's likely because plasma catecholamine levels and glucose production do not return to normal immediately with the cessation of the intense aerobic exercise. What about resistance training? I could not find reports on acute effects of a single bout of resistance training on blood glucose levels or insulin action in people with type 2 diabetes mellitus. Combination training may be more effective for blood glucose management than either type alone. Because contracting muscle increases GLUT4 activation, resistance training, which increases muscle mass, will increase the blood glucose uptake. And that's independent of the improved insulin sensitivity that we see with aerobic training. One issue with looking at the studies of combination training is that all of them had a greater total duration of exercise and caloric use when each type of training was looked at apart, so it's hard to compare studies. So that's a look at the acute effect of moderate aerobic, intense aerobic, and resistance training on type 2 diabetes mellitus. But what about the chronic effects of aerobic exercise training? We see improved whole body insulin sensitivity, enhanced responsiveness of skeletal muscles to insulin with increased expression and/or activity of proteins involved in glucose metabolism and insulin signaling. Moderate training may increase glucose synthase activity and GLUT4 protein expression and improve fat oxidation. Fat oxidation is a key aspect of improved insulin action, and training increases lipid storage in muscle and fat oxidation capacity. Chronic effects of resistance training also will improve insulin action and help improve blood glucose control. Looking at some science regarding resistance training, here is a small study out of Spain which looked at older men, only 9 of them though, 66 years was the mean age. They all had type 2 diabetes, and they participated in a 16-week progressive resistance training program. The resistance was set at 50 to 80% of their 1 rep maximum. All main muscle groups were exercised 2 sessions per week. A number of basal laboratories and anthropometric measurements were taken and compared at various time frames. They were measured 4 weeks prior to the onset of training, immediately before the onset of training, and at 8 and 16 weeks into the 16-week program. And here's what was observed. They ate more, which does not surprise anyone, but they didn't gain weight, and their visceral and subcutaneous abdominal fat decreased significantly, while no changes were observed in body mass. It was also noted that their insulin sensitivity increased by 46%. Their fasting blood glucose decreased by 7.1%, and their leg and arm maximal strength increased significantly by nearly 20% in each area. So again, regular resistance training increases insulin sensitivity in type 2 diabetic patients. Other potential benefits of weight loss in type 2 diabetic patients include weight loss, but if you're relying solely on exercise, it will probably take about 60 minutes per day to get considerable weight loss. Hypertension may be improved with slight reductions in systolic blood pressure, although diastolic blood pressure reductions are usually less. There's mixed data on the benefit of exercise in the type 2 diabetic with regards to the lipid profile, but higher levels of fitness does associate with lower risk of cardiovascular disease mortality. The ACSM and ADA recommendations, which are category A recommendation, is that type 2 diabetic patients should receive about 2.5 hours of moderate to vigorous physical activity per week for benefits. And all these benefits that you see here on this slide, even though they're mild, could be of benefit. Certainly non-diabetic patients will have more benefit with regards to weight loss, blood pressure control, lipid profile, and reduction of cardiovascular disease risk than the diabetic patient will. So when it comes to exercise prescription, the ACSM and ADA position statement recommends 3 days per week with no more than 2 consecutive days between sessions, because as you saw, the benefit of insulin sensitivity improvement will last up to 72 hours. And so you don't want to have that window close off. You want to get to a steady state of improved insulin sensitivity. The intensity should be moderate, which is 40 to 60% of VO2 max or 40 to 60% of maximal predicted heart rate. The duration, as we already mentioned, should be 150 minutes per week. The mode should be any exercise that uses large muscle groups and causes sustained increase in heart rate. And even though this doesn't seem very specific, the progression should be gradual. Pay attention to this slide because you're going to see it again. When it comes to resistance training, this is also recommended by the ACSM and the ADA for type 2 diabetic patients. The frequency should be twice a week, but 3 days a week would probably be better, and these should be on non-consecutive days to reduce the risk of injury from the resistance training. The intensity should be 50 to 80% of the 1 rep max, and the duration should be 5 to 10 exercises involving major muscle groups. Each exercise should be performed for 3 sets, and each set should have 10 repetitions. Both machines and free weights are good modes of resistance application, and again, the progression should be gradual. The risk of hypoglycemia during exercise in type 2 diabetics is low, especially if you're only treating with lifestyle changes or medications that are not secretagogues for insulin or insulin itself. But certainly the addition of insulin or an insulin secretagogue could increase the risk of hypoglycemia from exercise. Let's move over to the type 1 diabetes mellitus situation with exercise. Why should type 1 diabetic patients exercise? Better A1C control, more favorable BMI, less dyslipidemia, less hypertension, and fewer diabetes-related complications have been noted in patients who exercise regularly. This data is based on a cross-sectional study which looked at over 18,000 patients with type 1 diabetes mellitus and compared the most physically active, those who exercised greater than or equal to 2 times a week, to those who were less active. We're going to go a little bit backwards in our discussion compared to what we talked about with the type 2 diabetes mellitus patients, where we ended with exercise prescription. And here we're going to start with exercise prescription for type 1. You can see aerobic exercise frequency 3 days per week with no more than 2 consecutive days between sessions. Intensity moderate. Duration 150 minutes a week. This is the same slide that I showed you for aerobic exercise prescription in a type 2 diabetic. When you look at resistance exercise for the type 1 diabetic, it is also the same that we saw for the type 2 diabetic. Why is it the same? Well, just as in type 2 diabetes mellitus, exercise increases transport of blood glucose into exercising muscle through two specific pathways. The insulin-dependent pathway is more active at rest and after meals, but also there's a significant contribution from contracting muscle during exercise through the GLUT4 protein. Again, we saw this slide earlier when we talked about type 2 diabetes mellitus and exercise, just as we saw this slide earlier, which talked about the acute effects of moderate exercise on blood glucose, with increased blood glucose transportation into muscle, which can last for hours after the activity has ceased, and increased sensitivity to insulin, which can be anywhere from 24 to really 72 hours after cessation of the exercise. And just as we discussed in type 2 diabetes, utilization of blood glucose rises more than hepatic glucose production takes place, and blood glucose levels decline. The difference being that in the type 2 diabetic, plasma insulin levels also fall, so hypoglycemia is unlikely. In a type 1 diabetic, the plasma insulin levels won't fall because they're not endogenously producing insulin. So where hypoglycemia is unlikely in the type 2 diabetic, it can be quite likely in the type 1 diabetic if they're not careful about the use of insulin around the time of exercise. So it's very important that the type 1 diabetic considers several things prior to starting an exercise session. What is the current dose of insulin that's on board? What is their current blood glucose level? What is the most recent meal that they consumed and when did they consume it? What type of exercise are they planning and what is the duration of the exercise plan? Because all of these things can play a role in the risk of developing hypoglycemia during exercise. So let's start our discussion with type 1 diabetes patients and aerobic exercise. In most patients, blood glucose will decrease during aerobic exercise. The insulin concentration increases in the circulation at the start of exercise, and this happens even if the basal insulin is cut in half 60 minutes prior to the onset of exercise. And we're talking about a patient on an insulin pump here. Greater reductions of blood glucose are seen the more the patient is well trained. And hypoglycemia develops in most patients within 45 minutes of starting aerobic exercise, if it's going to develop at all. High-intensity interval sprint training promotes increased oxidative capacity of skeletal muscle in type 1 diabetes and attenuates the rates of glycogen breakdown. And this is theoretically protective against post-exercise hypoglycemia. And more conditioned patients have less blood glucose variability than unconditioned patients. Therefore, prior to exercise, both trained and untrained type 1 diabetes patients typically require increased carbohydrate load or an insulin dose reduction, or both. Aggressive reductions in insulin administration or a skip dose can cause hyperglycemia before or during exercise, especially aerobic exercise, and even mild activity can lead to development of ketosis. So again, great caution must be taken when reducing an insulin dose prior to exercise. Comparing this to resistance training, where we see better glucose stability than continuous moderate aerobic exercise. In fact, with resistance training, there could be a modest blood glucose elevation. Blood glucose typically rises with brief, intense anaerobic exercise or during high-intensity interval training. So with the aerobic, as you see on the graphic, aerobic exercise where you have increased insulin sensitivity and increased muscle transport of glucose through the GLUT4 protein, with that moderate aerobic exercise, you're going to get a decrease in blood sugar and possibility of hypoglycemia. If you're in a heavy, high-intensity interval training or anaerobic type of exercise, you may get elevation. And if you do mixed type of work, again, that may allow for things to stay at a more steady state. The risk of hypoglycemia after exercise is elevated for at least 24 hours, with the greatest risk of nocturnal hypoglycemia coming if exercise is performed in the afternoon. Nocturnal hypoglycemia could lead to death, so it's something extremely important, obviously, that we get right here with our diabetic patients. One of the problems is that patients who are performing high-intensity aerobic exercise or resistance training who get an elevation of their blood glucose may respond to that by increasing their insulin dose. And if this happens during the time frame when the insulin sensitivity is higher, then again that can lead to a drop overnight. So how do we adjust the insulin dose for exercise? Before we get to that, it's important to recognize that there's more to glucose control during exercise than just adjustment of the insulin dose. And so we have to consider pre-exercise blood glucose levels, dietary intake, as well as adjustment of insulin dose. So we'll get to the insulin dosing component in just a minute, but first let's take a look at this table and go through it briefly. Remember, there's no ideal blood glucose level for optimal exercise performance. It is suggested that in adolescent athletes it might be in the 110 to 140 range, but again, there's no great science to support that. So we have to look at glucose management strategies for type 1 diabetes mellitus patients preparing to engage in athletic activities. So again, we need to know what the blood glucose level is prior to the exercise event. If they're below target, and target is between 126 and 180 milligrams per deciliter, so that would be the target range to start exercise. If they're below target, well below 90 milligrams per deciliter or less, they need to eat something. They need to get their blood glucose level up, because if they're going to engage in moderate aerobic exercise, their glucose level will decline. And they should delay exercise until their blood glucose level elevates, because there's a risk of hypoglycemia in that situation. If they're near target, between 90 and 125, they should also have something to eat, maybe not quite as much as in the situation before. And because anaerobic activities and high-intensity interval training can elevate glucose levels, it's probably safe to go ahead and start those types of exercise, although maybe they should delay the moderate aerobic exercise for a little bit, and again, monitor for hypoglycemia. If they're on target in that 126 to 180 range, they can go ahead and start aerobic, anaerobic, high-intensity interval training sessions without any changes in the way they're looking at their glucose intake. Just remember that hyperglycemia can occur with anaerobic or high-intensity interval training. Same with patients who are in an above target range, 181 to 270, where hyperglycemia can occur with the anaerobic or high-intensity training, slightly higher risk than somebody who's in the on-target zone. If they're well above target, over 270, then they need to measure urine ketones. If the ketones are low, then mild to moderate aerobic exercise can be started, but you have to be prepared and monitor for hyperglycemia. And as the ketone levels elevate, the intensity of exercise needs to come down to the point where if it's significantly elevated, 1.5 millimoles per liter or higher, they should not be involved in their exercise activities in that situation. So your type 1 diabetic athlete now knows what their blood glucose level is and what types of exercise they may be considering based on that, whether they should be ingesting some additional carbohydrate before exercise or whether they don't have to worry about that component of things. Now let's talk about the insulin dosing strategy. And here's an algorithm which looks at insulin dosing, and we're going to walk through this. So the start point in all of these scenarios is the activity being done in a fasting or post-absorptive state with low levels of bolus insulin on board? That's the starting question to begin with in all of these scenarios. So if the patient is fasting or post-absorptive, they have to consider reducing their basal insulin dose prior to exercise, or they could have a snack or do both, like we were talking about before with the snack. So they're in a fasting or post-absorptive state. They have to consider reducing their basal insulin for aerobic exercise because it could drive their glucose levels down further. The next question is, are they on an insulin pump, which is the small diamond? If they're on an insulin pump, they can go ahead and reduce that basal insulin through the pump, or consider suspending the use of the pump at the start of the exercise. Glucose monitoring will tell them whether or not they need to eat something during the course of exercise or immediately after. And for the first meal consumed after exercise, which they suggest within 90 minutes, although it's been shown that people who consume a meal within 30 minutes of completion of exercise will have better glycogen replenishment. That first meal they should consider consuming 1 gram per kilogram of carbohydrate and reduce the insulin bolus by about 50%, and you can see that in the box there. You may want to screenshot and keep this algorithm. So let's go back now and start in the fasting or post-absorptive state, and you want to consider reducing the basal insulin dose. But this time the patient is on bolus dosing, so they're not on an insulin pump. So this takes some prior planning. Certainly the athlete in this situation wants to know that they're going to be exercising that day to make appropriate adjustments in their basal insulin that day, with a 20% reduction being considered. And again, they have to follow the pre-exercise glucose levels to determine whether or not they need to make adjustments in their eating patterns or the type of exercise they're going to perform. And just as we talked about in the scenario where the patient has an insulin pump, consideration for first meal carbohydrate load and alterations in post-exercise insulin dosing need to be considered. So let's move on now to a scenario where the athlete is going to eat something prior to exercise. So they won't be in a fasting or post-absorptive state at the time of exercise. And so what we want to look at is, my slide is having a little bit of difficulty advancing right now, so hopefully it'll catch up here in just a moment. So you are planning on eating, basically, and the question, here we go, then becomes, if you're not going to be in a fasting state or post-absorptive state, do you have time to change your bolus dose in order to affect the meal? And so if you're planning on eating, you can make that adjustment. So we're going to follow that yes part of the algorithm. So what we want to do is we want to reduce the pre-meal bolus dose in that situation. We also want to consider reducing the basal insulin dose if we have that ability. And if they're on an insulin pump, we can make the reductions in the insulin being delivered through the pump as we did in the prior algorithm. Now, if we follow the algorithm the same way, where we are not going to be exercising in a fasting or post-absorptive state, but we're planning to eat and we can adjust the bolus insulin given at mealtime, we want to go ahead and reduce that bolus injection. We also want to consider the reduction of the basal insulin dose. Again, my computer is having a little difficulty moving forward. Here we go. So we get to that point of the algorithm where now the patient is on bolus dosing instead of on an insulin pump. So this does change things. So again, we're going to have a meal, so we could change the pre-meal bolus, but we have to look also at our basal insulin dose, because if we weren't planning on exercise that day and we have our usual basal dose in, that could increase our risk of hypoglycemia. But if we know it's an exercise day and we're doing bolus dosing of insulin, we can consider a reduction in that basal insulin dose on exercise days. And so that's the big difference between the people on the insulin pump and the people who are doing bolus dosing, is pre-planning days that you're going to exercise and the type of exercise that you're going to be participating in, so you can make appropriate adjustments in the basal dosing. When it comes to meals, again, timing of meals and whether you're in a post-absorptive state or you're planning a meal immediately prior to exercise, that changes dosing as well with regards to alterations in the pump dose or in your pre-meal bolus dose. Again, this is very confusing, and I don't know that discussing it really gives it the justice it deserves, so I do suggest you take a picture of this for your files. Finally, if, let's say you're in a situation where you already ate and you have already taken your daily basal dose, and you already took your pre-meal dose and had a normal meal, and then you thought afterwards, oh, I need to go out and exercise still today. In that situation, you have no way of reducing the insulin given at mealtime. And so in this situation, you need to consider increased carbohydrate intake depending on the intensity and duration of the activity, because you have high levels of insulin in your system, and that's going to increase your risk of hypoglycemia. So you want to make sure that you reduce that risk by having appropriate carbohydrate on board in that situation. So again, quite confusing. I apologize for that. But make sure you have something like this available when you're trying to make these decisions to try to help out. And remember, everybody's different, and so these ranges are very, very wide, and close monitoring of glucose levels is very, very helpful, which is why patients who are actively involved in their treatment and are doing multiple readings, and that's where the continuous monitors come in handy, can really fine-tune their insulin dosing for exercise and keep themselves out of trouble. So when you consider other things with regard to the type 1 diabetic, insulin pumps may need to be removed for water sports. There are some that are watertight up to 12 feet of depth for 24 hours, but if there's a crack in the housing, even of the watertight devices, they're no longer watertight. Remember that insulin pumps may need to be disconnected for contact sports. I had my daughter was a collegiate volleyball player. All three of my daughters are or were, and one of them had a teammate who was a type 1 diabetic, and she wore her insulin pump while she played. She was a libero, so she usually wore it on her abdomen anteriorly because it was very unlikely she was going to be hit by the ball there, because her arms were usually in position, and she didn't want to put it on her hips because she would dive to her hips or potentially fall onto her back. And so she would wear it on the anterior abdomen, maybe off to the side just a little bit, so if she did have to go flat out on the floor, she wouldn't land directly on the pump, and she played and practiced with it on all the time. Remember, moving it around is important to reduce the risk of lipodystrophy. An injection site may be important too, because it can make a difference. The most common injection site for insulin is the abdomen. The thigh, shoulder, all these sites are certainly sites that can be considered. But if your exercise is going to include significant thigh muscle activity, you don't want to put the insulin in at the thigh, because insulin disappearance will increase by 135% in the first 10 minutes of leg exercise through a study done on cyclists, and remain 50% above resting levels after 60 minutes. And so you're going to use the insulin much more quickly and could have a hypoglycemic event in that situation. So to have a more steady state absorption of the insulin, you want to put it in an area that's not being actively exercised at the time, so the abdomen is an excellent choice. So let's recap a little bit here. Type 1 diabetes mellitus, they have a lack of endogenous insulin and need to be treated with insulin. Type 2 diabetes is an impairment of insulin sensitivity, and this accounts for 95% or even higher of the number of diabetes mellitus patients in the world. Certainly type 2 is more common in adults, but it's becoming increasingly more common in kids. The effects of exercise on blood glucose are similar in both the type 1 and the type 2 diabetics, and the exercise recommendations are also similar. And with aerobic exercise, it's 150 minutes per week, 3 days per week with no more than 2 days between sessions. Resistance training is important as well. 2 sessions per week, 3 days probably are better. And again, the recommendations, specific recommendations regarding the mode, the frequent, the reps, the sets, all those things are things we've discussed already. Moderate intensity aerobic exercise tends to reduce blood sugar, where high intensity aerobic or high intensity interval training may increase blood glucose. So it could go in either direction depending on the intensity of the activity. And certainly a mixed workout could lead to blood glucose levels which don't fluctuate quite as much. Type 1 diabetics need to know their blood glucose level prior to starting exercise so they can make adjustments in diet or adjustments in insulin dosing to reduce the risk of both hypo and hyperglycemia. And in the end, location of injection may matter. So I thank you all for joining me today. Again, I apologize for the confusion working through that algorithm. It's not a simple thing to understand or to explain, but I hope you found this helpful and look forward to the time where we get a chance to meet. Thank you.